Okay, now we're going to switch gears and talk about acute kidney injury. With an acute kidney injury, there are four phases. There's the onset, so in other words, whatever injured the kidney is the onset. Within usually 48 hours, you're going to see an increase in the creatinine level. And it's a rapid increase because it's an acute kidney injury. Then the patient is going to go through the oliguria stage. Oliguria means they have a urinary output less than 400 mLs in 24 hours. So they're not putting out the urine that you would normally expect of somebody. Then when the kidneys start to heal, they start diuresing. So they start losing a lot of water. They can diurese up to like 10 liters per day. So you have to make sure you're putting that fluid back in because they can die from low potassium and dehydration. And then the recovery phase can last about up to a year. And for some people, 10% of the people, usually older adults who get acute kidney injury, never recover and develop chronic kidney injury. So we want to make sure we can prevent this to save people's kidneys. There are three types of acute kidney injury that are classified according to the causes of acute kidney injury. So the categories are pre-renal, intrarenal, and post-renal. With pre-renal acute kidney injury, this is due to a low perfusion state, like the patient got dehydrated, so the kidneys aren't being perfused. If you remember in the anatomy and physiology lecture, I talked about the kidneys getting 20 to 25% of the cardiac output. So if the cardiac output is low, or the patient, like for example, is hypovolemic shock, their kidneys are underperfused. So you're going to need to know the causes of pre-renal. Most of the acute kidney injuries are due to pre-renal causes. So we always want to prevent it because remember I said that 10% of the people that get an AKI end up with chronic kidney disease, and we don't want that for people. When we talk about intrarenal types of AKI or causes of AKI, there is direct damage to the parenchyma of the kidney. So like inside the kidney is damaged. And this is due to medications, like your aminoglycosides like gentamicin, streptomycin, vancomycin, also like NSAIDs, platinum containing chemotherapy. Those can really damage the inside of the kidney and therefore they can get an AKI. People can get an AKI. It can also happen intrarenal for autoimmune diseases like diabetes and lupus can also cause an intrarenal AKI. And then finally, the post-renal occurs because there's usually some kind of obstruction in the urinary system. And we've talked about prostate problems earlier, and that could be an example, but so can renal calculi. That could be another example, or cancer like colon cancer in the area of the bladder or the ureters. That could be another example. So that's the types of acute kidney injury. In terms of the signs and symptoms of what you'll see in a patient with an acute kidney injury, it's the same signs and symptoms I talked about in the renal A and P lecture when I talked about a wet bed. So go and review that. The one thing they may not have is a drop in erythropoiesis because it's an acute problem. And remember, a red blood cell lives for 120 days. So they may not develop anemia, but all those other signs and symptoms I talked about, they will have, and you'll need to know the nursing interventions. And this is during the oligarch phase of AKI, and then also in chronic kidney disease. They're going to have all the signs and symptoms, including the anemia. Diagnostic testing for an AKI includes an increased BUN and creatinine. GFR is going to be decreased. They will have high potassium, so look for dysrhythmias, especially tall, peaked T waves. High phosphorus, high magnesium, and low calcium. Everything I talked about in a wet bed. They will have those electrolytes. The provider may want to do a kidney biopsy if they don't know what is causing the acute kidney injury. So go back and make sure you review the nursing implications of a kidney biopsy because patients can hemorrhage and bleed out. So that means you need to know how to prevent that. Chronic kidney disease progresses over time, and there's 5 stages where as patients go through these 5 stages, their creatinine clearance is going to keep decreasing as they go through these stages. So stage 1 and 2, it's mild loss of nephrons. Stage 3 is moderate loss, and they have to tighten up with their diet, fluid restrictions. And then stage 4 is where it's time to get the patient ready for what they're going to do in stage 5 when it's full-blown kidney failure and stage renal disease. So in stage 4, the choices are they can either do peritoneal dialysis, so you get them ready for that, or hemodialysis, or transplant, or they can choose a peaceful death. That's their right. So those are the stages of chronic kidney disease. The 2 most common causes of chronic kidney disease are hypertension and diabetes. And it's really important that you teach patients they need good control of their blood pressure and good control and tight glycemic control of their blood sugars to prevent kidney disease. Let's talk about health promotion and prevention of chronic kidney disease. Drinking 2 liters of water per day is helpful. This is before you have chronic kidney disease. Stop smoking, stop drinking, or limit drinking. Limit NSAIDs, aspirins, or any other kind of medications that can damage the kidney. You need tight blood pressure control and tight glucose control. The other thing is people with hypertension should have annual urine tests for protein in the urine to see if they're losing protein in their urine because that could be an early sign of kidney disease. In terms of assessment, they will have the same assessment findings as we talked about in the wet bed. Okay, so it's going to be the same as the oliguric phase in AKI and also the oliguric phase in glomerulonephritis. For pyelonephritis, if it becomes chronic, they will have the same signs and symptoms. And glomerulonephritis, if it becomes chronic, they will have the same signs and symptoms. If polycystic kidney disease progresses to chronic kidney disease, they will have the same signs and symptoms as a wet bed. Okay, the diet in chronic kidney disease involves a fluid restriction because obviously they can't put out urine, and if they're having hemodialysis, in between sessions, they still need to be on a fluid restriction. You need to restrict potassium to prevent dysrhythmias, those tall peak T waves, and deadly dysrhythmias as well. Restrict phosphorus to prevent osteodystrophy, which is when the bones get very brittle because of low calcium, chronic low calcium. Protein restriction. If before dialysis, patients with chronic kidney disease have to have a protein restricted diet because when they eat protein, it's hard for the kidneys to get rid of, first of all, but also it can make them very confused. And then they need a calcium-rich diet. So make sure you know which type of foods patients with chronic kidney disease can eat. When patients get to stage 4 chronic kidney disease, that's a time to educate them on their choices so they can have hemodialysis, peritoneal dialysis. They can also choose a transplant, but they may have to go on dialysis until a kidney becomes available. And they can also choose a peaceful death. That is their right. When patients go on dialysis, they need increased protein. So before dialysis, they need reduced protein loads. But then after dialysis, they're going to need increased protein in the diet. With hemodialysis, typically it's done 3 times a week for 3 to 5 hours. So it's a commitment. It's a full-time job. Peritoneal dialysis varies. It can be continuous. It can be intermittent. The patient can do it themselves, which is often a benefit for patients that want to travel. So those are the different types of dialysis. Hemodialysis can only be done in patients who have stable vital signs. If they don't have stable vital signs, they're going to get continuous hemodialysis, and we're not even going to talk about that. It can also be done in acute kidney injury as a temporary measure. Typically, when patients have chronic kidney disease, they will need it for life unless they get a transplant. The indications for dialysis is acidosis, so patients with chronic kidney disease suffer from metabolic acidosis, electrolyte disorders, remember the high potassium, high phosphorus, high magnesium, and low calcium, but also uremic symptoms like high BUN and creatinine. It's going to lower all those labs after dialysis. Intoxication is another indication. So patients with chronic kidney disease can't clear alcohol from their bloodstream. So that may be an indication. Or even like drugs intoxication, like for example, if they're on digoxin, they may become toxic from digoxin and may need emergent hemodialysis. Fluid overload is another indication. Uremia, I've talked about in the A&P lecture, so make sure you know the signs and symptoms of uremia. Patients that are going to undergo hemodialysis need IV access, so they can get a temporary tunneled catheter. Sometimes the tunnel catheter is used long term. It's a dual lumen catheter. It typically goes in the subclavian vein. It's only used for dialysis, so you can't use it to infuse IV fluid or draw blood from, and it's only accessed by the dialysis nurse. For long-term hemodialysis, the vascular surgeon will make an AV fistula, so an arterial venous fistula. And if you look at this picture, what they do is they connect a vein with an artery. And what it does is it makes this fistula that can be accessed by the dialysis nurse to perform hemodialysis. And what you would do is assess the 6 P's. Okay, you want to make sure you're doing your neurovascular checks. You're going to auscultate for a bruit. That's how you know that the AV fistula is patent. Palpate for a thrill. Encourage range of motion on that extremity. No BPs, no sticks, no heavy lifting, no watch. They should not sleep on that side, so you need to explain that to them. They shouldn't wear jewelry. Anything that could be constrictive on that side. The nursing implications of hemodialysis include obviously getting vital signs before and after and during. But you want to weigh the patient before and after, because 1 kilogram gain or loss equals 1 liter of fluid. And for anybody with kidney disease, you want to encourage daily weight so you can monitor their fluid balance. Patients are going to need labs before and after dialysis, so the BUN and creatinine should go down after dialysis. Hemoglobin should go down, and potassium, phosphorus, and magnesium should also decrease after dialysis. Complications to hemodialysis include hypotension, probably the most common complication. Patients aren't allowed to eat during dialysis because that can drop their blood pressure, but also just getting the fluid off can drop their blood pressure. So if they're in a dialysis chair, you make sure the head of the bed is up, and make sure you take their vital signs to confirm they have hypotension. They'll be dizzy and have tachycardia as well. Clotting of the vascular access device can also happen even with the fistula. So you would monitor for that. And then bleeding. So after hemodialysis, they cannot have invasive procedures for 4 to 6 hours because they're going to be high risk for bleeding. They use a lot of heparin during hemodialysis. So make sure you have protamine sulfate on hand and make sure it hasn't expired. Protamine sulfate is one of those drugs that you want to have in your Pyxis. However, it's not used that much, so I always used to check the expiration date when I worked in vascular lab. And then disequilibrium is another syndrome you're going to monitor for after and during hemodialysis because it involves signs of increase intracranial pressure because the patient may get cerebral edema from hemodialysis. So typically what you'll see is a headache, a change in the LOC, nausea, vomiting, and confusion. Your patient may need anti-seizure medications like phenytonin. So it's really important that you watch for these complications. Peritoneal dialysis is a great option for patients with the cognitive ability to do the procedure for themselves, especially if they like to travel. It's a good option. So what happens in peritoneal dialysis is dialysate is instilled into the peritoneal cavity. And the dialysate is ordered by the provider, and there's different combinations of fluid that can be ordered. The peritoneum then acts like a semi-permeable membrane to filter out the toxins and the electrolytes. So one exchange involves filling the peritoneum with dialysate, letting it dwell according to the provider's order, like it might be dwell for 20 minutes, dwell for an hour, and then draining the dialysate from the peritoneal cavity. Patients need an intact peritoneum to undergo peritoneal dialysis. So patients with multiple abdominal surgeries and adhesions are not going to be candidates. And also patients with polycystic kidney disease would not be a candidate for peritoneal dialysis. The dialysate has high sugar concentration, so you need to watch for infection, but you also need to make sure you're checking their blood sugars because they could develop hyperglycemia. Now, with the outflow bag or the drainage bag, if you look at this picture, when you're draining, you want to make sure this bag is lower than the abdominal cavity so it can outflow. If you're not getting the same amount that you put in the drainage bag, roll your patient from side to side. First, you're going to check for kinks because that's the least invasive way, right? And then you're going to roll the patient from side to side, make sure they're in a straight alignment so it can drain out, the dialysate can drain out, and also make sure they're not constipation. That could be a factor in the reason that they're not draining. Nursing interventions around the peritoneal dialysis procedure. Sometimes you have patients from the community that come into the hospital that they do the peritoneal dialysis at home, but if they're sick for some reason, they come to the hospital, you might have to do this procedure for them. So again, you're going to weigh before and after because that's the best measurement of fluid balance or non-invasive best measurement of fluid balance. You're going to check vital signs, check the glucose before and after, measure abdominal girths, and measure the input and output of the dialysate. Dialysate should be at room temperature. When patients first start with peritoneal dialysis, they're going to start with smaller amounts because over time you have to build up the peritoneum to be able to stretch. Otherwise, they're going to be in a lot of abdominal pain. And you want to make sure you explain to the patient how to avoid constipation. Complications of peritoneal dialysis include peritonitis, which can result in death. So it's really important you can identify the signs and symptoms of peritonitis, which include a fever, increased white blood cells, abdominal guarding, meaning they're in so much pain you can't palpate their abdomen, a board-like abdomen or a rigid abdomen. That's the classic signs of peritonitis. So you want to make sure you're watching out for those. Hyperglycemia, because the dialysate has high sugar. Hyperglycemia can lead to infections such as peritonitis, so that's why you have to watch that. So with peritoneal dialysis, it is strict aseptic technique. Okay, so it's really important you understand that. Poor outflow can be due to constipation. It could be due to kinks in the drainage system. So make sure that you don't allow your patient to get constipated, and that if the outflow is not draining properly, check for kinks, turn them side to side, make sure they're in good alignment. Hyperlipidemia happens over time with patients with undergoing peritoneal dialysis, and they can develop hypertension from that if they don't already have it from renal disease. Infections, so monitor for temperatures. Fibrin clots are almost expected to develop in the catheter that you do peritoneal dialysis in, and it could cause like leakage around the catheter site, so you would watch out for that too. Intestinal perforation is always a factor that you would need to watch for, and we'll be talking about intestinal perforation in our future lectures and of abdominal conditions.